Right. So, basal cell carcinoma is the most common cancer. Worldwide, annually, there's about 4 million diagnoses, followed by lung at 2.5, breast at like 2.3 or something like that. Is arising from these basal cells, this membrane that separates the lower dermis and that epidermis in your skin. And if you do a quick image search, you'll find something that looks like this. Do you know why you don't see a lot of mathematical models of basal cell carcinoma treatment? It's because it's not interesting. And we need more of this, but this is what it is this is resectable. It goes away, you cut it out and all is well, But about 1 to 10% of these, and here's your warning, there's some graphic photos ahead. Some of these grow either to neglect or due to just aggressive nature of the disease. They grow very large. They grow in spots that are unresectable. There's no real definition of unresectability, but it's just the fact that there's some structures, say the nose or the ear, they're hard to take out with a scalpel without too much damage, and then also to reconstruct something that's that you can live with, right? So here's just kind of a subset of what you might see. And I think what we found is the more we see, we think we've seen it at all, that something else appears, right? But there is some treatment here. So a lot of these respond to hedgehog inhibitors. They have that upregulation. And so then they start to have systemic treatment rather than local. And so one of the problems with that, though, is there's a lot of toxicity involved with this treatment. So we have been working on this clinical trial that is randomized into 4 arms. One has a continuous treatment. One has this fixed intermittent. This is shown to be useful in multi-lesion but not advanced local disease. And then there's 2 adaptive arms. This is sponsored by Genentech, Roche, and they're doing this arm D. They developed this drug, so they're really interested in the PK and PD dynamics, and they're also interested in toxicity. We wanted to add some resistance in there. There is a chance of resistance to this drug, and so we have both of these arms testing out adaptive treatments. And one of the first things we noticed here is, a lot of endpoints, a lot of the treatment decisions are based on long axis diameter as a measure of burden. And if you look at this here, you see here's one of the lesions of the first patient we got. And this first one is 3.76 centimeters. We give 4 weeks of treatment. And then we see this one, and it actually has grown in size. But if you look at it, it actually looks okay. It looks like it's doing better. So we had to do something more with these pictures. And what's nice is we have these nice facial pictures taken every 2 weeks that we're using to make treatment recommendations on, but we needed to do something better to quantify the burden. So first, what we do right now, we're hand annotating these. We have to identify the scale, circumscribe the tumor. We circumscribe a little part of normal skin that we can use to transform into a brighter space. We're using kind of HSV color space to apply to the tumor so that we get this nice bright tumor. And what we wanted to do is link this to the biology. So just looking at normal wound healing processes, there's certain colors involved that you see. When you have an open wound, it's bloody and you start to get a scab and different colors appear. You have inflammation that's a little yellow, and as the skin heals, it changes color. So we're trying to relate this, the biology to the color. And so we trained a random forest classifier by identifying these little regions that we want to classify as these different physiological phases within the wound healing process. And then we can have classify the rest of the regions, and it does a pretty good job. You'll see other things here, like we have to account for tattoos and pen marks, and these don't, weight into the final burden. And we have to identify how much weight each one of these regions gets. And we're still working on this, but it's something to work with to make treatment recommendations on every few weeks when they come in. And so if we look at this image over time again, and we look at how it's changed with the length, and then we look at the color metric, we can see that it has improved over time, and we can use this as a nice measure. And you can see over the induction period, all patients go through this 8 weeks on treatment and 2 weeks off. You can see this long axis measurement just kind of stays the same and then increases. If we look at that in the color metric, it kind of does this decrease and increase again, just like we see with other measures when looking at adaptive therapy. But this patient also had 6 more lesions that we were following over time, and there's a lot different, each one of them. So we have long measurements there. We look at the color measurement, color metric, and you can see how this changes, but we needed a way to make decisions when there's multiple lesions that might be acting differently. Some of them respond well to the treatment and some of them don't. So what we came up with is every single lesion, and I'm showing 2 here on the left, we've defined bounds. We have an upper bound and a lower bound, and we define these usually based on their kind of natural dynamics. So as they reduce in size with the treatment on, that defines their lower bound, and wherever they are from the beginning or coming back up, that might be their upper bound. And if they're really large lesions and we might want to make sure they stay smaller, we'll reduce that upper bound. But basically these bounds, if you hit the lower bound when the treatment is on, then you stop any lesion. And if you hit any lesions upper bound when the treatment's off, then we take the treatment off. So it might have several lesions that define the treatment dynamics based on that. And then we do a prediction. So I'll show you on the next slide how we're using the math modeling to predict ahead whether we'll cross these bounds or not, because we'll have a 2-week difference before the next treatment is decided. And then we have to translate this back to the long axis, which they're not defining this color metric in the clinic. So we have to put it back into terms that they can measure in the clinic. So this is just a simple sensitive and resistant Lotka-Volterra type model. And we have these interesting pharmacodynamics that happen as this drug gets bound up. It's no longer efficacious to killing these cells. So we had to really take that into account. And that comes from some published work that this Genentech has also been working on, a little simplified version. I'm showing you one here where we fit some of these treatments and then our predictions. And I'm showing you one where there is like a real probable resistance as we start to see this increase while the treatment is on. And so our next recommendation was to stop treatment. There's a lot of possible noise in these measurements, and so maybe it hasn't quite hit that resistance yet, but it was time to stop treatment and allow it to grow back a little bit. And so back to this first patient with the 7 lesions, they ended up being on the trial for 2 years. So this is a controllable algorithm using this metric and this strategy. And here's kind of, the ongoing results. We're about halfway accrued right now. You can see this is ours. We're arm C in the middle here. The other adaptive arm is arm D. You can see where it's red is where treatment is on and black is where treatment is off. And you can see that they have a more aggressive treatment strategy. But they also have a little bit more toxicity. So some of the reasons for ending treatment is toxicity, but in some of these cases, if they reduce the tumor enough, they'll go off trial and do another treatment, radiation or surgery. But you can also maybe appreciate that we have gotten a lot of patients with a lot of lesions. So compared to some of the arms. And this is what it looks like with the long axis. But the color metric, maybe it kind of shifts how things look. But either way, you can see that there's for each patient, how many tumors they have that we're following and what sizes they are, at least to start with. And to kind of try to understand, we're only looking at the superficial, photograph of the outside of these lesions over time. We're also trying to understand, is there something about the top of the tumor that could tell us something about what's going on deep underneath the surface? So Masood and Sandy and I have been working on this agent-based model that's been carefully calibrated to mimic wound healing first, and then to put in some cancer to see how it grows. So we're taking this and we're also trying to relate it back to all these images that we're taking. Can we take a cross section of these pictures that we see and try to relate it to the agent-based model? And he's found that there's some of these parameters that are pretty important here. The growth rate and the EGF consumption are really important to kind of determine the morphology of these, whether it's growing outward or if it's all ulcerated inward, and if there's anything underneath that could indicate why that's happening. So it's ongoing work, but I think it's been useful to go through that. And furthermore, we're doing more spatial analysis on these. It's really kind of early times on that, but taking a look at all these classified regions and seeing what's the frequency of these and how does it change over time. Looking at, kind of radial frequencies of different regions in different ways. And so this is work that clinically it's Zenab that has we started with a melanoma adaptive therapy trial and moved on to this one as well. So she's been really great to work with. And Masood has taken over a lot of the clinical analysis work, and Sandy and I helping out here. And we recently had Ken help out as a dermatological pathologist to help out with more of that understanding what's happening with the physiology. So
we have time for a couple questions. I'm supposed to run this thing.
Oh.
Yeah. So two people put up their hand. One person I've seen frequently do it. Who is the person back there? Okay. Sorry, Bob, I'm going to go to, and I'll move up. Yeah, that.
Thank you so much for your talk. Wow, this microphone's really strong. I know you had mentioned that you haven't calibrated yet for pen marks or tattoos, but how are you stratifying your patients based off of like Fitzpatrick's skin typing, like more melanated skin tones? Would they show up as more severe disease in your model?
We haven't had a lot of melanated skin tones. These are white, a lot of it's not really happening. But I mean, there is a brightness that we do, but these are all white skin. I mean, it's not very common in the first place.
Oh, okay.
But yeah, I mean, we do some kind of normalization through this brightening, and I don't know, we kind of hit the ground running, and I found something that works. It could be improved, I'm sure, but yeah, I'm interested to talk more if you have ideas.
I think I do have an idea that might work. We should chat later.
Cool, yeah.
Yeah. Thank you so much.
Maybe we can get the next speaker to start setting up. And Bob, if you want to ask your question.
Thank you. Usually the skin is viewed as hypoxic because there's no vessel penetration beyond the basal membrane. And so there's a diffusion reaction kind of dynamic.
Mm-hmm.
Are the tumors vascular or are they also avascular and therefore hypoxic? And does that have do you think that's a factor in how they respond?
Interesting question. I mean, yeah, so right, all the vessels are in the dermis, but you see them, you can actually quantify in some of these tumors, you see the vessels, and there's probably some way to nicely quantify, but I don't think they all do. And I mean, yeah, and especially these ulcerated ones, I think you're down in the dermis. But if you have to grow past that, you have to grow some vasculature to actually keep that going, right? So it's interesting. I think we're still figuring it out.
So thank you so much, Jill. That